All right, so we talked about these factors that affect lung volume. So when we look at the first factor, we talked about lung recoil or elasticity. That's just due to the connective tissue and simple squamous epithelium that makes up the lungs. They're stretchy. So when the lungs expand with an inhale, they easily deflate when we exhale. When those contracting, those respiratory muscles relax, then they go back to their resting position because of that elasticity, that recoil. So that acts inward on the lungs. And we also know the bottom one, surface tension, acts inward on the lungs because of what? What causes surface tension? Water molecules. They want to form a, what do water molecules want to do? They want to form a droplet, right? Because they're attracted to each other. They're polar covalent molecules. They have a negative side. The oxygen's slightly negative. The hydrogens are slightly positive. So the hydrogens of one molecule is attracted to the oxygen of another molecule, and they want to form a water droplet. So we don't find that in other liquids like rubbing alcohol. Rubbing alcohol does not have that surface tension like we see in water. So surface tension acts inward on the lung. So if we have too much surface tension, too much fluid, those lungs can't expand. And what is the molecule that breaks up the surface tension and counteracts that and helps us expand our lungs? Surfactant, yeah. And what are some things we can tell our patients to do to increase surfactant production during the healing process? Deep breathing and using that, yeah, the incentive spirometer. Yeah, that's really important that we get them to do that. Oftentimes that thing sits at the bedside and doesn't get touched. So you got to keep reminding them. You pick it up and say, so are you doing this 10 times an hour? 10 times an hour, not a day. I just had a patient recently that I said, you know, remember it's 10 times an hour? Yep, I think I did it about 10 times yesterday. Like, no, 10 times an hour. Well, of course, while you're awake, we're not going to wake you up to do it, but 10 times an hour. So just really reinforcing that because they forget. And they get distracted because they have family in. And then it's a good time to tell them, too, when the family's there, because then the family will push it. And you got to tell them why. Patients need to know the why. They don't just need to be told the what. Do this because the doctor said so. Tell them why, because we don't want you to get pneumonia. You'll recover faster after your surgery on the heart or lungs if you do this incentive spirometer. Okay, pleural pressure always has to be negative. If we get any kind of penetration of that pleural space and pleural pressure becomes positive, we call that a pneumothorax. Pneumothorax. Pneumo means air. Thorax is chest, so air in the chest, just because we penetrated those membranes. And how do we repair a pneumothorax? How do we get that negative pressure again? Do you remember what we do for patients? I think I showed you a picture. What? A chest tube. Yep, we set it to negative pressure, and that does the kind of sucking action to keep that negative pressure in that pleural space. So then compliance, remember compliance is due to those membranes. If they're sticky and touching each other with that fluid in between, there's surface tension in that fluid, so the visceral and the parietal pleura are attracted to one another because of the water in there. So when the lungs go, or when the chest cavity moves out, the lungs go with it. The lungs are compliant. They move with the chest cavity. So that is a force that acts outward on the lungs. So if we have a stiff lung, if we have a cancerous tumor lung, it can't move with the chest cavity. So then we have reduced compliance. But if we have a ballooned lung, overinflated because of blown out alveoli, we have high compliance because they're kind of blown out and they move easily with the chest wall because what's missing, if I have blown out alveoli, it's like taking a sponge and picturing every little hole in that sponge is an alveolus. It's like taking a piece of that sponge and just taking a chunk out of it, just biting a chunk out of it. Wouldn't you see a big hole there, right? So it's not going to soak up as much water, right? Because there's less sponge there. It's just the same thing in someone with COPD. There's less gas exchange because there's no alveoli. There's these big holes in the lung. So if there's big holes in the lung, which of these factors is reduced in a person with COPD that prevents the lungs from deflating? Which of these help deflate the lung, or not deflate, but bring it inward for exhale? Yeah, Yeah, elastic recoil is reduced because there's no alveoli to reduce in size, right? They're just blown out, so they're stuck large. And then Tish was correct, surface tension. If there's no alveoli, there's no water molecules lining those alveoli to be attracted to one another to cause those lungs to go down. So people with COPD have barrel-shaped chests. And you'll hear them when they're doing activity and get out of breath. They're not actually out of breath. They're full of air that they can't get rid of. So they have to go to get that air out. So they have to use extra muscles, not just the external intercostals and the diaphragm. They have to use abdominal muscles, other what we call accessory muscles to get that air out. It's called trapped air. They feel like they're suffocating because they're full of air. It's like breathing through a straw. You can breathe in through that straw, but try to move around only breathing through a straw. That's what COPD feels like. After a while, you're going to feel like you have so much air that you can't get it out enough. And then that's a very uncomfortable feeling. Okay, so compliance is just things that, factors that help the lungs move out with the chest wall. So if you have pulmonary fibrosis, that means you have a stiff lung. That means the lung has had so much chronic inflammation that it gets stiff, hardened, less elasticity. It's fibrotic. Fibrosis is it's just a stiffening, thickening of that lung tissue. Pulmonary edema, what does edema mean? Too much what? Fluid, too much fluid. And pulmonary edema is caused by like congestive heart failure. If you've got a heart that's not pumping enough blood and it's full of blood, the fluid backs up in the whole blood vessel system, and the excess plasma that's supposed to go to the kidneys and be urinated away ends up leaking out into the lung tissue. So now you've got this fluid around the lungs, and we call it congestive because it causes a cough and gets around the lungs and fills the alveoli, and people have a really hard time breathing when they have that pulmonary edema. And again, more water droplets, right? It's harder to overcome that surface tension. And then respiratory distress syndrome, this is common in people that have, they were born prematurely, and when their lungs aren't fully developed, they don't have good surfactant production, so they need a lot of oxygen and positive pressure to keep the lungs inflated and to breathe, those tiny, tiny little babies. And as a result of that, they end up with just chronic inflammation and distress throughout the respiratory system. So we see kids, when I worked on pediatrics, that were born very premature, that were coming in, babies, like a 1.5-year-old, but they were born so tiny that their lungs are just permanently damaged. So anytime they get a cold, it turns into bronchitis, pneumonia, they're in the hospital. I found that the interesting thing about pediatrics, if you want to work on pediatrics, if you ever thought about it, it's a different type of nursing because, for one, kids are mostly healthy, right? So kids come in with respiratory stuff, and they need oxygen and maybe a little Tylenol for fever. So that's what you're doing. And then respiratory therapy comes up and gives them a breathing treatment. So it's pretty easy stuff, right? And then the hard part of pediatric nursing is kids with cancer who need their chemo, because they have to stay. Adults with cancer go get their chemo at the outpatient clinic, and then they go home. And if they would develop a fever or start to feel funny, instantly they're told to come in because they're very much at risk because their immune system is low. They're very much at risk for infections and death. Kids are even more at risk for that. So they don't want to mess around and have any child at home where maybe the parent's not paying attention, or maybe the child's at daycare and somebody misses a fever and that child dies. So we keep kids in the hospital during their chemo treatments for that reason. So the minute they get a fever, bam, we're on top of it and protecting them from those side effects. So that's the hardest part of pediatric nursing, I would say, is the chemo management. But you get some really close relationships with those kids because sometimes they're on your floor for 6 months. And then when it's time for them to go, do you think they want to go? No, because they have this whole team of cheerleaders that's been taking care of them for 6 months. They're like the superstar. What kid doesn't enjoy attention, right? These kids love that. And then it's time to go home back to their routine where they're just haven't been in school for 6 months and, they're just this plain old kid in a desk. They don't like that so much. It's a huge mental adjustment for those kids. It's tough. And even the parents, too. Parents are crying and hugging everybody because they develop those relationships, too. So anyway, and then you also get kids with cystic I'm sorry, cystic fibrosis, yes. So that's a respiratory issue. And then you have kids with cerebral palsy that were developed either something happened after birth, drownings, shaken baby, some type of suffocation. They develop cerebral palsy, or they're born with it. Something happened in utero or during the birth process. And those kids have lots of lung issues. So I did enjoy my little bit of time on pediatrics. But the big thing is to keep in mind that kids are mostly healthy. So it's not going to be as invasive type of nursing. If you like that kind of stuff, you know, then critical care and intensive care and some of the step-down units are a good idea. So we talked last time, you know, just talking about how pressure and volume are related, right, and drives airflow. So the difference between other ions, like the action potential, it was concentration differences that drove ion flow across the membrane, right? Like sodium and potassium we talked about, they flow across the membrane because of concentration differences, high concentration to low concentration. Well, when you talk about movement of air, it's not an ion. Air is air. It's a gas, so it's pressure differences. So we're going to analyze some pressure differences during the breathing process. So we have to, first of all, change the volume, which changes the pressure. So we're going to use real simple numbers when we do this by using 0 as kind of our starting point, and then it becomes higher than 0, like +1, or less than 0, -1, unless it's this pleural pressure that can be -4. So intrapulmonary pressure is the pressure inside the alveoli. So intrapulmonary, P-pul, is pressure inside the alveoli. And then atmospheric pressure is outside air pressure, which we know at sea level is 760 millimeters of mercury. But we're not going to analyze those big numbers. We're just going to set that equal to 0. So let's say 760 is the same thing as 0, just to make it easier. So if we look at this diagram here, intrapulmonary pressure is 0. So the pressure inside the lungs is 0. The pressure outside the body is 0. So is air moving? Is there a pressure difference? No. And this happens between breaths. When you've inhaled, there's a slight pause, then you exhale, there's a slight pause. That pause is when the pressures are equal. So that means the muscles aren't contracting or relaxing, they're in between those stages. So when we're resting, what is pleural pressure? Inside the pleural space, what does it say there? It's always negative, right? It's always negative because the lungs, you know, they don't come completely flat against the chest cavity doesn't come completely again down to the level of the lungs. There's a little space in between there, so there's a little stretch. The lungs elastic recoil inward, and the chest cavity sits at its resting position, so there's a little stretch of that space, which is -4. So transpulmonary pressure is just the difference between the pressure in the alveoli and the pressure in the pleural space. We call that transpulmonary pressure. So it's just a difference between these two pressures. Trans means across. So let's watch this animation here. So we see the diaphragm contracting, the pressure in the alveoli decreases because what happened when the diaphragm contracted? What happened to the volume? It increased. And pressure and volume are opposite each other, right? If I increase the volume, I decrease the pressure. So when that moved down, that P alveoli that was 0, or our textbook calls it the P-pul, right? The pressure in the pulmonary pressure, same thing as P alveoli. So that dropped to -1. Then we have 0 is bigger than -1, right? So air flows from higher pressure to lower pressure. And then at the end of inspiration, what are those pressures going to be? Correct, both 0. They're equal. Then the diaphragm has to relax to change the volume. So decreasing volume causes what for pressure? Increase. So now this is going to rise above 0 to be +1, and air is going to flow out. So expiration is a passive process. Would you agree? There's no action potential going to these muscles because they're relaxed. So inspiration is active. We need an action potential to contract the muscles, but expiration is just a turning off of that process. Okay, so back to, actually I'm going to make sure that this is, sometimes my YouTube keeps going during my PowerPoint. Okay, so this is just kind of a step-by-step diagram of what we just watched in the animation. So just be aware that, you know, when we're inhaling, that drives that pressure inside the alveoli down until we're done breathing in, then it's equal to the barometric pressure, and then it increases when that diaphragm relaxes for air to flow out. So changes in pleural pressure. Well, let's look at this real quick. What happens to the pleural pressure during inhalation? What would you think? As I'm inhaling, the chest cavity is going outward. So I'm stretching that space even more. So pleural pressure during inhale would become more negative or less negative? What do you think? If I'm stretching that space more? More negative, yeah, because I'm increasing the volume. If I stretch that space, aren't I increasing the volume? And that's going to drop the pressure. So it's more negative than the resting negative pressure, but it should never be positive, right? So sometimes, let's just talk about this pressure in there. So sometimes we get fluid in there, and when it says left ventricular failure, that's heart failure. So when we have heart failure, we have backup of fluid into the lungs. The left ventricle specifically, because where does the left ventricle get its blood from? The left atrium, which has the pulmonary veins in it, right? So it's coming from the lungs to the left side of the heart. So if it's backed up, the left ventricle can't pump it out via the aorta. It backs up in the left ventricle, back up to the right atrium, back up to the, but we have closed valves. But what happens is the atria, when the left AV valve is open, the heart is already full from the previous cycle, so they can't fill like they should. And that excess fluid and blood backs up into the lungs, and the plasma leaks out of the capillaries, the pulmonary capillaries, and causes a pleural effusion. So what we have to do then, these patients come in and they have really low oxygen because it's like thickening that respiratory membrane with all that fluid, right? That oxygen has to go through that big fluid space. It's like taking the Mississippi, and the Mississippi, if you needed to swim across it, if you were an oxygen molecule, lacrosse was the alveolar wall, and lacrescent is the pulmonary capillary wall. If we doubled the width of the Mississippi, it would be harder to swim across it, right, if someone was a swimmer. So it's the same thing with pleural effusion. It just thickens that distance for those gases to travel. So people come in and they're really short of breath, low oxygen levels. So we have to go in with the fluid in between the ribs in the side of the chest and pull that fluid out. Now, a student, he's not here today, was telling me he worked in the military, and when they do that in the upper part of the lung. But in the hospital, we do it in the lower part. Like when we put a chest tube in, it's in the lower part because that tube is more, less disturbing to the patient when it's coming down off the body rather than at the top of the lung. But he said out in the field, they'll do a fluid aspiration up at the top of the pleural space. Anyway, so that's called a thoracentesis, when you go into the thorax and you pull that fluid out. And we can get up to 2 liters. We did it bedside in one of my clinical assignments, And he was just pulling it out with a large syringe and then putting it into a container and pulling more, putting it into a container. And I mean, it was almost 2 liters we pulled off. Can you imagine 2 liters of extra fluid around your lungs, how miserable you would feel? And how better you'd feel when we were done, right? So it's a very popular procedure that we do quite often. And then about a day later, you take the dressing off. There's just a little poke site there, not a big deal. So then a pneumothorax we talked about is any time you get air in there and you lose that pleural pressure. So pleural pressure is equal to atmospheric pressure. So that's 0, not negative, and the lung collapses, and we call that atelectasis. We already talked about that. So then to look for a pleural effusion, you come in with shortness of breath, the doctor looks, you've got a history of heart failure. The first thing he's going to order is a chest x-ray. So sometimes this happens right at the bedside if the patient is so bad, in such bad shape they can't even go down to the x-ray room. They bring the x-ray machine right to the bedside. This happened this weekend for my patient. She had just sounded terrible. And I asked I think something more needs to be done. I said the patient is really struggling to breathe and should be getting better and seems to be getting worse. So the doctor said, well, let's get a chest x-ray. And they look for fluid. So on the right, you can see, well, on your left, on the right side of this patient, your left as you're looking at it, you can see black, but there's kind of a haziness to it, and that's the lung tissue, because lung tissue doesn't pick up x-ray, but it does a little bit. You should see a little haziness of the lung tissue. But on the left, fluid picks up that x-ray. And look at how much fluid is on the left side. This person is miserable. There is no gas exchange probably going on the left side. Solid fluid. This would be an example of pneumonia in this case, because it's just on one side. So that would be like a left lung pneumonia. Pretty serious stuff. Pneumothorax. So look at the left side of this patient. See the hazy kind of gray lung? Look on the right side where the arrow is, just below where the arrow is pointing just below it. See how black it is? There's no lung there. Where is the lung? You can kind of see it here along the midline. So you can see right here, that's the lung. What? Oh, did it? So this is the lung collapsed along the midline. And this is the heart right here. So, and this is lung tissue picking up a little bit of that x-ray. So chest x-ray is a very popular thing to order when we're looking at trying to diagnose what the issue is with breathing. So another thing we can do with patients with chronic lung disease is we have them blow into a spirometer, which is a big fancy machine, has a little mouthpiece on it. They blow in and out, in and out. They say take a couple of normal breaths. The couple of normal breaths is this. Blow in, blow out, blow in, blow out. With a normal, healthy 21-year-old male, that's what all the A&P textbooks represent. So if you're a 21-year-old male, this is all about you. So 500 mils in and out. Then at the end of inhalation, so when you go with the normal breath, if you go that much more, that's what we call your inspiratory reserve is. So there's more room to fill those lungs with air if necessary. So when do we use this here? When we hold our breath to go underwater when swimming, when we're taking a drag, heaven forbid, on a cigarette, we're using that inspiratory reserve. When we're yawning, we're using inspiratory reserve. Taking a deep breath before a cough, all that stuff. So after the end of a quiet expiration, we have some extra in our lungs, but look at the difference. We have a lot more inhaling ability than we do exhaling ability. What would happen if we exhaled all the air out of our lungs? What would happen to the lungs if there was no air in there? It would collapse, yeah. So we don't want to blow all the air out of our lungs. Once that pressure is equal, we're good. So we want to keep that residual volume in there for constant gas exchange. So there's always some air remaining in the lungs, so we have continual gas exchange between breaths. So that's our expiratory reserve volume. So when do we use that volume? This piece here, this 1100 mils. When do we use this? Thank you for demonstrating, Noah. Coughing, exhaling, heaven forbid, from that cigarette, laughing, right? Just anything where you're, what? Yeah, well, that's an inhale. right? So that would be your inspiratory reserve. But laughing, sneezing a little bit, depending how hard the sneeze is. So that's that expiratory. So we want to maximize this when we use the incentive spirometer. This is what we measure is when they're inhaling. We want to make sure that that stays high. So what we do is we test patients before surgery so they know where they were at before surgery. So then after surgery, we want to get back to that level. And they can say, oh my gosh, I mean, I've had patients, they're in a lot of pain. They just had their chest cracked. That's a huge deal. And then look at them like, oh my gosh, I'm such a wimp now. It's like, no, you just had surgery. We're going to get back up there. But this is where you were at. Let's get back up there. So that's where the nurse comes in, and you have to have good pain control, because if a patient's in a lot of pain, are they going to try their hardest on that incentive spirometer? No way. Walking the hall is really important, getting patients to sit in the chair, because laying back, that doesn't help the lungs expand. Sitting in the semi-fowlers, laying back position in bed, that doesn't help. Getting patients to sit upright in the chair helps expand the lungs, or even just standing at the bedside for a little bit. Say they have really poor mobility, they can't move their feet very well. Get them just to stand up every now and then, get their shoulders up, get their ears over their shoulders. That's what I tell patients too, because you see, sometimes 60-year-old men who have had, their chest cracked, and they're able to recover. 60 is considered young. 60 to 65 is considered young on a cardiac floor. But if they're in a lot of pain, they're walking like this, or pushing their IV pole. Oh, you got to tell them, ears over your shoulders. Even my dad, I tend to walk kind of hunched shouldered. It's a bad habit. But I tell my dad, he's starting to get the old man look. And I'm like, yeah, ears over your shoulders. You've got good posture. And tell your patients that, because sometimes they don't realize when they're in a lot of pain. Okay, so this just describes the volumes. I'm not going to expect you to know all these volumes. So just know what reserve means. Inspiratory, you know what inspiratory means, hopefully, right? It means to inhale. So the reserve is what's left that you can inhale with. Expiratory reserve is what's left that you can exhale with after normal breathing. So tidal volume is just normal breathing. I don't know what's causing that flashing screen there. And then residual volume, we can't get rid of, right? That's what's there for gas exchange. Capacities are just combinations of these volumes. So we can add these together. And we use these numbers in a respiratory, the respiratory therapist is going to use these numbers to figure out where to set the machines if they need supplemental breathing, ventilators. I'm not going to hold you accountable for the capacities. Just know that they exist, but I'm not going to have you memorize or know all those. It's too much. It's overload. So gas exchange then. What drives gas exchange? There's a little bit more than just pressure differences. It depends on how thick the membrane is. Like we said, if I've got a fluid-filled membrane because of congestive heart failure or pneumonia or a drowning victim, that's going to be thicker, so it's going to be harder for things to diffuse. The diffusion coefficient of the gas, this is a chemistry concept. There's a solubility, the ability of the molecule to dissolve in a liquid is different for every molecule, and it's based on chemical properties. We're not going to analyze that. That would be like a biochemistry class. We're not going to go into that here. But it's just a number that's unique to each gas. And what I can tell you is that oxygen has a lower coefficient of diffusion than carbon dioxide does. So carbon dioxide more easily flows across the membrane than oxygen does because of this coefficient, diffusion coefficient. And then the surface area of the membrane. So a person with COPD that has less alveoli, they're going to have less diffusion of gases because they have a reduced surface area. And then the partial pressure of the gases in the alveoli in the blood. So a patient on 2 liters, a healthy patient on 2 liters is going to have more gas exchange than a person on room air that's exercising, right? So it just depends on the pressures in the between the 2 spaces, the alveoli and the blood. So what we see too is that if we look at areas where there's increased ventilation or increased blood flow, we're going to see more gas exchange. So obviously if the capillaries are dilated, going to the lungs, like under the sympathetic nervous system, we're going to see increased gas exchange because of that. All right, so oxygen and carbon dioxide are the two major gases exchanged across the respiratory membrane. So we know that the direction of oxygen movement is always going to be from the capillaries to the tissue cells. Because if we list the order in which oxygen is highest, what would be first? Yes, because that's where it comes from, right? It comes from trees outside. So here we can see the PO2, so this is the partial pressure of oxygen in the inspired air, is 160. In the alveoli of the lungs, it's 104. So there's a drop there. Once it goes from the outside air where the trees are into the lungs, we've lost, what, 56 millimeters of mercury? That's because there is mucus, water vapor in the lungs from mucus that causes a diluting of the oxygen. And we also have old air in the alveoli that has less oxygen that again is going to dilute the oxygen coming in from the outside air. So we just, the airways and the alveoli dilute the oxygen coming in a little bit. So it's not quite as concentrated by the time it gets down into the alveoli. But it's still good. It's 104 in the alveoli. That's the highest in the whole body, right? Because it just came from the outside air. So this is the highest PO2 is in the alveoli. Then when it leaves the alveoli, goes into the pulmonary veins. There's 4 of those on the back side of the heart, and it leads to the left atrium, right? The left side of the heart is receiving fresh blood. So then from there, so from the alveoli to the pulmonary veins, we see a drop to 100. So we lost 4 millimeters of mercury. And why is that? I think we talked about that last time. Why do we lose? Yeah, in the lungs, we need to keep the lungs alive, right? So the lungs need a little bit of oxygen. So we lose a little bit of oxygen to the alveoli itself to keep them alive, and then comes back to the heart. The heart doesn't use a lot of oxygen any oxygen in the chambers, but remember at the base of the aorta are the left and right coronary arteries, right? And that serves over the surface of the heart. So that's part of the coronary artery arterial supply. So then that leads and comes down the systemic arteries, and the tissue cells are constantly soaking up oxygen because of cellular respiration, right? Remember the Krebs cycle and electron transport chain are constantly sucking up oxygen. So where would the oxygen in the body be the lowest? If it's highest in the alveoli, where would it be the lowest then? In the tissue cells. And here it says pressure of oxygen is less than 40. So it's always going to be less than 40. Which means there's going to be a nice pressure difference, right? It's going to be higher here than here, so that's going to push oxygen constantly into the tissue. So there's always that pressure difference. And then if we look at carbon dioxide is very low out in the outside air. So that's always a pressure difference driving carbon dioxide out. And then if we look at where it's the highest, where it's produced, right? We said oxygen is produced by the trees outside, so that's where it's highest, and then it comes into the alveoli, that's second highest. And then where would carbon dioxide be the highest? In the tissue cells, yeah. So it's always greater than 45. So then oxygen is always higher here compared to the capillaries, so then it's going to leave the tissue cells. And here we can see it's still 45, so it's always greater than 45. So it's going to diffuse, diffuse, diffuse until it's equal. And then when it hits 45, it's going to go back to the heart, up to the alveoli, where it's going to be blown off. So what is the PCO2 in the alveoli? 40. So it's going to go off and be exhaled. So if we look at the pressure differences though, look at the pressure difference here. It goes from, for PCO2, it only goes from 45 to 40 in the lungs. The difference between the pressures is only 45 to 40 from the blood to the lungs. But if we look at oxygen from the lungs to the blood, it's 104 to 40 There's a bigger pressure difference for oxygen than there is for carbon dioxide. So the push for oxygen is much higher. And why do we need more of a push to get oxygen from the blood into the tissues? We go back up. We talked about the diffusion coefficient of gas. What did I say is higher? Carbon dioxide, yes, carbon dioxide diffuses more easily based on its diffusion coefficient compared to oxygen. So oxygen needs a larger pressure difference in order to push it across the respiratory membrane or the membranes of the blood and the tissues. Okay, so that's the difference there, is just the molecule. So oxygen always moves from alveoli to blood, and blood is completely saturated with oxygen when it leaves the capillary because of, we go back to our blood chapter, what molecule is inside red blood cells that picks up oxygen? Hemoglobin, yep. So hemoglobin, those molecules inside the red blood cell, pick up oxygen and they carry it. Carbon dioxide is always going to go from the tissues to the blood because of, that's where it's highest, is in the tissues. So if we watch this little animation here, oops. Okay, that animation's not working. That's right. We'll just continue on here. So oxygen is transported mostly by hemoglobin. So most of the oxygen that comes into the body hops onto this hemoglobin molecule. So here's a red blood cell. The little circles inside represent hemoglobin molecules, and oxygen is carried by hemoglobin. Most of it is. So that means if we have some stopping of breathing, so there's not fresh oxygen coming into the body for about 5 minutes, all these hemoglobin molecules that are carrying oxygen, they're going to dump it to the tissues to keep the tissues alive. So we have about 5 minutes, right, before we're going to pass out from not getting oxygen, because hemoglobin is a reservoir of oxygen. So when we look at someone's oxygen saturation on their fingertip and it's 95%, we know that 95% of their hemoglobin is saturated with oxygen. So that's good. That means that they've got a reservoir of oxygen. But now if I look at someone's oxygen saturation and it's less than 90%, it's down in the 80s, then I know that's not a good number. We want to see oxygen saturations above 90. So if it's only in the 80s, that means they're not getting good flow. Because if we're breathing normally, we should be filling up all of our oxygen, our red blood cells, our hemoglobin molecules with oxygen. So most of oxygen is transported by hemoglobin, and then a little bit stays in the plasma just as a dissolved gas. Carbon dioxide, some of it is bound to hemoglobin, so we do see 23% binding to hemoglobin. So it's the globin part of the hemoglobin molecule, where oxygen binds to the heme part of hemoglobin. Most of it, though, is converted into bicarbonate ions. A bicarbonate ion is HCO3-. So when carbon dioxide diffuses into the blood, it combines with water to form this acid, which is carbonic acid, which then breaks up into ions, different ions, which is bicarbonate ion and hydrogen ion. So this bicarbonate ion is what carbon dioxide is transported mostly into. And it's a little bit more of a complex process than is shown here, and we'll hold you accountable for that process in advanced A&P. But for our level right now, all you have to know is carbon dioxide is converted to bicarbonate ion in the red blood cell, and that's how it's transported. So because of that, these two ions are regulated by the kidneys. So the kidneys can control the pH of the blood, because bicarbonate is a base and hydrogen ion is an acid. So you don't have this slide in your packet, that's okay. This is an advanced A&P concept, so I'm not going to hold you accountable for this, but you'll see this in advanced A&P. So are we on this? Is this the next slide in your packet? Not yet. Let me see what I've got here. I have this. I'm just looking here. Yeah, respiratory areas in the brainstem. I don't have a picture. You have a picture, but I don't. Yeah. Okay. 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 So the medulla and the pons, those are the parts of the brain that control breathing. The medulla controls heart rate as well. So the brainstem is where the medulla oblongata is, right? So this is what controls breathing. So if someone has damage to the brainstem, they're a goner. They lose control of blood pressure, heart rate, breathing. So the medulla is where the phrenic nerve is controlled. So the phrenic nerve is what contracts the diaphragm, causes it to move down, change the volume, change the pressure, air flows in. So the medulla is the direct controller of the phrenic nerve and also the intercostal and abdominal muscles if we need accessory breathing. If we want to tap into those inspiratory reserve and expiratory reserve, those muscles can help with breathing if necessary, right? Do you ever spend a night coughing or a night laughing with friends and your abdominal muscles hurt the next day? That's a respiratory thing. So the pons is just a regulator of the rhythm of breathing. So the medulla sends the action potential to contract, and then that action potential is done, and the muscles relax, and that switching from inhalation to exhalation is controlled by the pons. So the pons is a helper. So here is the pons. Remember, it's that larger swelling. And here's the medulla. So we can see from the medulla, we have these nerves going to the phrenic nerve, going to the diaphragm, external intercostals. And then the pons, though, influences those nerves. So again, the switching between inhalation and exhalation is controlled by the pons. But the direct action potential to those muscles is delivered by the medulla. Okay, so when we have, again, this rhythmic inspiration, so the medulla constantly sends that action potential. And then when we stop inspiration, it's the pons that has inhibitory neurons, which will prevent that action potential in those respiratory muscles. And then we see a relaxation of those muscles to result in expiration. So inspiration is an active process that relies on action potentials. Expiration is inhibited action potentials from the pons. Other things that can control ventilation is the cerebrum. The cerebrum is our thinking brain. So if you had some upsetting news, whether it was good or bad, that might cause you to increase your respiratory rate. If you have too much carbon dioxide, that causes more of that carbonic acid to build up, and that would cause an increase in the respiratory rate because the respiratory system is trying to get rid of that excess acid by increasing the depth and the rate of breathing. And then there's a lot of other factors. If you look, we can see that the brain, so our emotions, our voluntary control of breathing, like if you want to slow your breathing down to do relaxation exercises, we can override the medulla and the pons in that respiratory rate. If we're talking a lot, sometimes we have to control our breath so we're not taking an inhale in the middle of a sentence, right? And if you keep talking, and then you get to the end, you have to go, right? So that's how we're overriding that medulla. Like I said, reduced pH or increased carbon dioxide, one causes the other. So increased carbon dioxide drops the pH because of that carbonic acid that's formed. You get excess hydrogen ion building up in the blood. So that's going to stimulate the respiratory system. We have chemoreceptors in the carotid arteries and the aorta. So if there's decreased oxygen detected by those special sensory receptors detecting oxygen, that's going to tell the medulla to increase the respiratory rate, right? If we have decreased oxygen, that makes sense. And then we also have stretch receptors in the lungs themselves. So if I go and inhale really big, I don't want to pop my lungs, right? So we have what's called the Herring-Brewer reflex, that if they get overstretched, look at the sign here. It's a negative sign, which we're going to stop breathing to deflate the lungs so they don't burst our lungs. And this is happening in exercise. When a person's running a sprint and they just can't take another breath because they feel like they're exhausted, that's the Herring-Brewer reflex. It's just causing the lungs to deflate, even though they might need more oxygen. And if you just move your muscles and joints around, just do this, just the movement of your joints causes an increase in respiratory rate even before you need it because of the exercise. Just the movement causes that. And then when you're in pain, we have a lot of pain that increases the respiratory rate. So that's why you want to control patients' pain when they have bad lung issues, because you don't want them breathing too much and losing that oxygen. So Herring-Brewer, we just talked about that. Babies, that's pretty much all that regulates their breathing. So if you look at babies breathe, infants, it's really irregular, and they have little pauses in between breaths, and then they'll go. If you ever watch a newborn breathe, it's kind of scary when it's your first one and you don't know what to expect. You're like, breathe. But they do. It's natural. So when we exercise, you know, obviously we see increased ventilation. We're going to see increased lactic acid production because sometimes we're not getting enough oxygen in the early parts of exercise, but then it goes away as we catch up. But as we age, our ability to move mucus is decreased. We have less gas exchange across the membrane because sometimes the lungs stiffen a little bit, increased fluid, increased risk for pneumonia. So that's why we get our flu shot and try to keep our elderly patients healthy. They're more at risk for complications. So that concludes the respiratory system.